And I was formally trained in the Navy in orthopedic surgery, and then was able to do a fellowship at Harborview Medical Center at the time that Jens Chapman was there, and trained with those guys, and learned an incredible amount about both spinal trauma and spinal deformity. And then was able to return to the military institution where I trained as staff, and so spent several years there training residents. And then when retired from the military, I settled in Coeur d'Alene, Idaho, which is just across the state here from Seattle, Washington. And so it's an honor to be here today with each of these folks. And my transition from a large academic center to a much smaller community with a smaller economy, yet still having the same desires to do academic type medicine, really brought about a ton of pressure to sort of think about the way we did things, and trying to look at ways that we could address, say, deformity and other complex spinal cases in a community that doesn't have the same medical infrastructure that exists here in Seattle or might exist on the East Coast, where I was involved in academics. And so I turned to a model. I'm a big cycling fan, and in 2011, there was a new upstart cycling team called Team Sky. And what was interesting about these guys is they had come from the track. It was a bunch of British cyclists that suddenly announced to the press and to the world that they were going to start this new road cycling team. They were going to leave the velodrome, so they were going to go outside for the first time, start riding on roads. And their goal was to win the Tour de France. And they actually picked this guy, Bradley Wiggins, saying, this is going to be our guy. And the entire cycling community essentially laughed at these folks, saying there's absolutely no way that you can win the Tour de France. You guys don't even know what you're doing outside of the velodrome. And what their philosophy was, which was very interesting to me, is that rather than trying to find ideas from people that would give them 10% improvement in performance or otherwise, they actually went to the cross-country skiing community, the swimming community, all these different endurance sports, and they said, bring us ideas that are going to make 1% improvement. And so they were much more interested in 10 ideas that would give 1% improvement, as opposed to one idea that might give 10% improvement. And sure enough, that very same year, 2011, Sir Bradley Wiggins wins the Tour de France, shattering all expectations and previously conceived notions in the cycling world. You can actually see one of his teammates with his head down in the back of that. That's Chris Froome, who wins the next four Tours de France using the exact same philosophy. So they took the cycling world by storm. So the idea is that while we're performing these complex deformity surgeries, one, we need to build on the foundation that we've been taught. Like I said, I was the recipient of a rich heritage training at Harborview Medical Center and learned a lot about complex deformity. And my early exposure to sort of minimally invasive approaches to this ignored a lot of the same foundational principles that I was taught as a fellow. And I thought that if we're ignoring these foundational principles, are we going to be successful? And so these are complex surgical interventions in patients that are typically somewhat complex from a physiological perspective. And the question is, are we able to safely perform these surgical interventions at a non-large academic center? And we're really building on the shoulders of giants. We've already talked about many of these people. We've heard from them today, Dr. Christopher Schaffery, Dr. Jens Chapman, Dr. Lanke, et cetera, that have really helped us understand a lot of the philosophies that we need to take into account when we're looking at different strategies to approach deformity surgery. And so I kind of have these highlighted here. Really, my goals in deformity surgery are a powerful correction of sagittal balance and coronal balance, to achieve an actual fusion along the construct itself, and then to achieve decompression where necessary, right? And is there an actual tissue, or is there a patient benefit if we can develop more tissue-friendly techniques for this? And so I'm going to look at today specifically the first 50 patients that we did at our institution after adopting robotic guidance as a modality for the second portion of this case, what we call the posterior stabilization. And so these are the first 50 patients that were done. You can say that they resemble somewhat of the learning curve associated with this newer technology. But again, I'm not looking at this technology as a game-changing technology by itself, but as part of those marginal gains in which we bring together several different ideas and philosophies to accomplish the goals for our surgical patients. And our outcomes, we're both looking at patient-reported outcomes, but also radiographic outcomes in these patients. And I'll describe the method itself here. The surgeries were performed in 2 separate stages. The first stage is an anterior column reconstruction. We're typically from L4 to S1. We will use an axis surgeon and do an anterior lumbar interbody fusion. From L1 to L4 as necessary, we'll do a lateral lumbar interbody fusion, and that's the anterior column reconstruction stage. It allows for indirect decompression of the neural elements, and it also allows for realignment of the spine, both in the coronal and the sagittal planes. Here's an example of then after the anterior column reconstruction, looking at the CT scout image, looking at the before and after in someone with primarily a coronal deformity, less so a sagittal deformity. What's most important between these stages is the performance of the physical examination. And so relying on the idea of indirect decompression in this case and saying, have we accomplished our goals in someone with, say, a left-sided L5 radiculopathy, a careful physical exam can help resolve this. And in most instances, these patients will tell me my leg symptoms have completely resolved, which allows us then to move forward with just a posterior stabilization. And so looking specifically at the second stage of this procedure and trying to do so in a way in which we adopt strategies so we're not necessarily looking at the primary anatomy. I don't need to strip muscle from bone. You can see here on the pictures that I have demonstrated, that picture in the center there, actually on the left-hand side is the midline structures. On the right-hand side, I've opened up just a very small window from T10 down to L1 where I decorticate the spinous process and the spinolaminar line, and then we use our biologic of choice, and then immediately at the beginning of the procedure, I close this back up. And so my approach thus far has just been a midline incision down to fascia. I clean off the fascia bilaterally, and then we rely on robotic-aided navigation then to find our landmarks that otherwise we'd be looking at through a large open incision. We can also do mini open decompressions as the physical examination between the cases would lay necessity for. In this particular case of 50 patients, we did a mini open decompression only 4 times, so about 8% of the patients themselves. The advantage of robotic assistance and image guidance, this actually allows me between surgical interventions to plan my construct and plan it in such a way in which I can rely on anatomic placement of the hardware itself to allow for easy flow of rod passage in a percutaneous technique, and then also to powerfully perform derotational maneuvers so that we can reduce the deformity of the spine by sequential tightening of the set screws through the reduction heads so that we can perform that derotation. And interestingly, one of the things that was not really immediately relevant or in my conscious when I began doing this, but through using the robotic arm as a drill guide, so to speak, there are far fewer passes in which you have to establish your trajectory. Your trajectory is already established. And so typically now I'll use a high-speed burr and go immediately to the screw, and we'll be able to place that screw. And we noticed in these first 50 patients that not in a single patient did I have pull-out of those screws that I had placed even in osteoporotic bone during the derotation of the spine. And I attribute that to just the constant axial approach to the pedicle as opposed to moving my hand around and trying to get into the right location. And so we'll see if we can get the video going here. This is an L1 pedicle, which you can see is quite narrow. This is obviously relying on the user interface, and we can talk a long time about the accuracy of the user interface. This is a very important tool in which the user of the tool needs to be familiar with how the tool works and know how to troubleshoot that tool so that they can recognize if it's not working for any reason. But again, a very powerful way in which we're able to very quickly place an L1 pedicle screw in someone with a rotated L1 vertebral body with small, challenging anatomy without having to actually look at that L1 vertebral body through a large open incision. And so our results, we looked at the first 50 patients again. Average age of the patients were 7 years old, 64% were female. In almost every case, the posterior stabilization was done 1 day after the anterior column reconstruction. In the cases we did not do that, it was more of a scheduling conflict than it was related to any medical conditions with the patients. The average estimated blood loss for the posterior stabilization was 200 milliliters. Average operative time about 208 minutes. Average screws placed per procedure was 16. No patients had to return to the OR for implant malposition, and no screw pull-out during deformity reduction at the index stage. And the average length of hospital stay was 5 days, and that included the first stage, the second stage, and their recovery. So essentially 3 post-operative days post-op. And no patients required transfer to another facility with an ICU. And so these procedures are all being done in a surgical specialty hospital in which we have a devoted hospitalist to take care of these patients post-operatively, but no ICU capabilities. And the outcomes radiographically, showed an overall reduction of 14 degrees in the scoliotic curve, an increase in lumbar lordosis of 12 degrees, and getting our mismatch to be within 10 degrees of the lumbar lordosis and pelvic incidence. And the patient-reported outcomes, again, in the ODI, an improvement from 46% pre-op to a 30% post-op, and average pre-op VAS was 6 and post-op was 3. And so there are obvious limitations according to this study, and I would argue that using these techniques are very facility-dependent, surgeon-dependent, and patient-dependent, as well as understanding of the tools that you're using, each of these, and the marginal gain that it can provide for you. But this is a retrospective study in which we're looking back at these 50 patients. This is a single surgeon at a single institution, and we began using this technology in 2019, around summer time frame. And so one of the major impediments to this study was also follow-up, in which early in 2020, we lost our ability to really see a lot of these patients to the pandemic. However, thankfully, I've been able to follow these patients longitudinally since that time. I don't want to belabor the point. We have a couple minutes, I think, right, in which we can go through at least a single case here. But this is the application of these principles to this was actually the very second patient that we did with this posterior stabilization technique. And so things to keep in mind is, again, the patient characteristics themselves, the T-score of -2.6. So we did bone optimization in this patient for about 3 months before surgery. But really what brought her in and what her primary complaint was the right costal margin then on the right hemipelvis. So she had a rib-on-pelvis deformity. That's what was most bothersome to her. If you see her x-rays here, she is quite a bit translated to the right-hand side. I applaud the surgeon that had done the work previously. It would be tempting to look at that scoliosis and say, hey, we're going to fix that scoliosis, but I think they were able to sit there and say, hey, she's got an L4-5 problem, let's fix it. And they did so in such a way that was friendly enough that we were able to still be able to do a relatively virgin scoliotic reconstruction afterwards. But some of the challenges that come up as a result of patients that have been operated on by others. Her T8 to L3 Cobb angle was 48 degrees, L3 to 21, 24 degrees, 2 centimeter rightward shift from the C7 plumb line. Less of a sagittal imbalance, but she does have a SVA of +9 centimeters. And so again, applying this approach, a 2-stage reconstruction in which first we did bone optimization. In her case, we did the L5S1 ALIF as she was already fused at L4-5. We did our L1 to L4 lateral interbody fusion. That particular surgery was 25 milliliters of blood loss lasting 2.5 hours for both of those approaches. The second stage then, in between stages, we got the CT scan in which we were able to do our robotic planning when the patient's not asleep and bleeding on the table. It's an excellent exercise in being able to visualize this is what we're going to do so that when you show up for surgery itself, it's just a matter of execution. But T4 to ilium instrumentation, this required 2 separate registrations with the robotic system based on our thoracolumbar CT scan. And I'd be happy to talk about the logistics of that in any forum today if you'd like, but we won't get into it for this talk. And then we were able to do the mini open from T4 to L1, that same technique in which I just opened up a little bit of the midline so that we could pack all our biologic in along the spinous processes and the spinolaminar line. Again, right at the beginning of the case, then I close that fascia and we proceed with robotic-assisted screw placement. The second portion was approximately 500 cc's of blood loss and took about 3.5 hours with this result in which we're able to actually navigate around the pre-existing hardware. If any of you are familiar with this hardware, it was a workhorse of Medtronic way back when and is incredibly difficult to remove. I think most of the removal instruments that we have for it we purchased on eBay and just flash when we need them. In this case, we were able to navigate directly around it, and I felt good with anterior column support that we wouldn't risk rod fracture or otherwise. And so she was 4 inches taller immediately following the second surgery. It was interesting. She had actually presented with her 2 sisters that were also 4'11", and she left the hospital 5'3", and her sisters were very upset with me. But lumbar lordosis of 55 degrees with a pelvic incidence lumbar lordosis mismatch of only -4 degrees after surgery and an SVA of 0.5 centimeters. So in conclusion, use of intraoperative navigation, specifically robotic assistance, can be an important adjunct to posterior stabilization in the complex deformity correction. Again, I consider this a tool in our bag of tools for the marginal gains in which we can provide really good deformity surgery to individuals in less capable non-academic scenarios. And the feasibility of this technology can really be used for correction of sagittal and coronal deformities while relieving patient symptoms, and doing it in a tissue-friendly way that I hope over time we'll be able to demonstrate not only saves a cost to the patient as far as their recovery time, but a cost to the healthcare system as patients spend much less time in the hospital, et cetera. And then a lot of future research obviously is still needed to look at the long-term impacts, especially from a cost-conscious perspective as to the use of these enabling technologies, and really whether it's worth our while and worth our time and worth our money. So turn it over to questions.
Thank you so much. Great talk. I'm definitely an advocate of really trying to do that anterior column. I have access to some navigation here. And one of the challenges that I've found is sometimes when you have these deformity patients, you really put a perfect screw in, it's right down the pedicle, and then you go to place your rods and they're very disparate. What do you do in terms of the preoperative planning, in terms of a more kind of medial starting point for one screw versus the next? Does that take a lot of time to get it right?
That's actually, and again, the difference may be between freehand navigation, where you're also able to construct a plan beforehand, and then using robotic assistance with this, a drill guide essentially through the robotic arm, is the idea that you can very micromanage those deltas between those screws. So I agree. Say, I showed on my very first slide a woman with a large L3-4 lateral listhesis, right? And so if you anatomically place your screws at L3 and L4, there will be a large disparity. And so what the preoperative planning allows me to do is perhaps at that L3 level, I'm going to be a little bit medial. At the L4 level, I'm going to be a little bit lateral. So when I go for rod passage, that I'm going to be able to successfully pass that rod. The other thing that I sort of preach in this regard, though, is that you're never passing the rod from T4 to the ilium, right? You're passing the rod from T4 to T5, T5 to T6, T7 to T8. And if you look at it with that sequential approach, there's little tricks I use, for example, using set screws so that I can reduce the rod underneath the fascia to the next reduction head, and various other things. So if you look at it all from, I've got to get it to T4 to ilium with one pass, that'll hurt you. If you look at our current time to actually put in screws, from a T10 to pelvis, it's about 40 minutes now with robotic assistance, and that's just placing the screws. Whereas the case itself lasts about 2 hours, 45 minutes to 3 hours. The rest of that case is really, the meticulous rod passage and various other things. But that's been made, quite a bit easier by the preoperative planning. And so to answer your question, you take advantage of the technology to sit there in your head and say, when I get to this point of the case, I'm going to make it a little bit easier on myself by doing this. Yeah. Please, Dr. Gupta.
So I have a question about, I think you showed some really impressive cases. How do you release the arthritic or almost ankylosed facet joints? Do you do that by patient selection, where you know that the discs are open or the facets are not too bad or ankylosed before you choose these patients? And if you have such a patient, do you do a routine open where you remove the facets and release it before you put the instrumentation?
Yeah, so in this specific case series, believe it or not, we kind of got away with doing no osteotomies, which was somewhat surprising to me. I don't specifically select my patients for this approach based on ankylosis, et cetera. If there's ankylosis in the lumbar spine, the strength of also using intraoperative navigation is sometimes complex anterior column osteotomy that needs to be done before my anterior column reconstruction, or as a partner to that. So a lot of times I'll use navigated COBs, and I can go ahead and do multiplanar osteotomies through the anterior space, say at L1, 2, and then I was sort of laugh that I'm breaking down a fusion so that I can affect the fusion, but really we're breaking down the fusion so that we can affect derotation and correction of the spinal issue. And then I'll typically put still a spacer in there, et cetera. But the thing that you run into there is after you've done your osteotomy a lot of times, then obviously you'll see subsidence of the spacer. But really what I'm doing in that case is an anterior column release. For the thoracic spine, it's different. I will do a mini open posterior osteotomy similar to what you just just demonstrated with the Masonics, so that we can release those areas along the concavity of the curve and get a better correction. And so to that end, as I'm already opening up on one side so that I can put my biologic in, not infrequently I'll open up on the side that I need to do the posterior osteotomy, do the release. I'll dissect out just to the facets that I need to be able to do my release on, and I'll do a formal open release and posterior osteotomy just like you demonstrated. And then I can just drop my bone graft in there, sew it up, and we start putting screws down.
So great cases. Really enjoyed the last one and seeing a TSRH pedicle screw system, I think, which was state of the art. When I finished my training, it was either that or Synthes or Moss Miami. There were only 3 choices out there. And they were a pain in the neck putting in and taking out. So I've never seen that bypass like that. That was really quite nicely done. One comment I would make, and I'm a fan of MIS, and I think this is the future of where things are headed, and we'll have another talk from Bob Eastlack here in just a moment, but I think both of you guys, Bob and you both, appreciate what I call the fundamental principles of spine surgery, which I try to teach our fellows, and I consider those really, there's 4 that I think you have to think about for any fusion surgery, and that's the biology of bone healing, the anatomy of spinal decompression, neurologic decompression, the biomechanics of spinal fixation, and the anatomy of spinal alignment. And what I do see in our community is oftentimes technique supersedes these fundamental principles, and it 100% of the time leads to an adverse outcome for a patient. And so I think it's leaders like you guys that really appreciate these principles and adhere to them with these new techniques that are driving things forward. And I really appreciate the talk you gave about the fusion in particular. That's one, and the spinal alignment is another that oftentimes we see just poorly done with these longer constructs. So do you have a comment on that? And do you see the same kind of failures from other surgeons?
Yeah, I guess my comment would be that I attribute a lot of what I was trained to do in the past as our ability to succeed in what we're doing right now, right? Because again, like you mentioned, if you were strictly trained from a minimally invasive standpoint, you sat there and said, well, I can do 1, I can do 2 levels, why can't I do a deformity case? Without being specifically trained on deformity and the fundamentals of deformity correction, I think it would be somewhat more difficult, and you would lose sight of those principles. I've seen talks in which people have placed percutaneous screws, percutaneous rods, and you hold up your hand and say, hey, where's the fusion happening? And they say, it'll happen. That is a dissatisfactory way to approach deformity, because we know that all of that hardware that we put in there is merely a scaffolding to aid with the bone physiology that you were talking about. We need to be able to get bone to fuse to bone, otherwise it's going to break down sometime in the future. What I'll be interested to see, and what we don't know yet, and in this particular collection of 50 patients, we have seen a very low prevalence of proximal junctional kyphosis, but what my hope is, by less disruption of the proximal elements of the spine and keeping the muscle intact, keeping the blood supply intact, that perhaps that's healthier for proximal junctional kyphosis. In this group, I have seen it in 2 of our patients that we've had to extend on up. And if you compare that to historic controls out of 50, that's a pretty good track record. Since the first 50 patients, I've seen it more often, and most of the time it's attributable to one of my mistakes, which is disregarding the fundamental principles of deformity correction and perhaps being a little overly aggressive in my sagittal balance correction.
Great comments. All right.